Rare skin cancer is not one diagnosis. The exact pathology name, depth, risk features, and disease-specific staging questions determine the next step. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. Wait, hold on a second. Before we dive into all that map stuff, can't we literally just tell what we're looking at from a quick photograph? You know, it's a super common question, but actually, a photograph cannot establish the diagnosis. These tumors can completely mimic everyday things. They might resemble a benign cyst, a simple bruise, maybe a scar, a rash, a sty on your eye, eczema, or even a much more common standard skin cancer. So a picture might definitely make you ask, hey, do we need a biopsy here? But representative tissue and the exact pathology, those are always the decisive factors. Think of the term rare skin cancer as just a giant umbrella label. To figure out exactly where we're going, we need a really clear pathology routing map. This map separates out into completely distinct lanes. We're talking Merkel cell carcinoma, DFSP, AFX, PDS, extramammary Paget disease, sebaceous carcinoma, microcystic adnexal carcinoma, and cutaneous angiosarcoma. The absolute key takeaway here is that the exact pathology name, not just the fact that the tumor is rare, is what actually dictates your very next step on this map. Let's zoom in on a specific fork in the road so you can see exactly how this builds. Take atypical fibroxanthoma, or AFX, versus pleomorphic dermal sarcoma, or PDS. If you just take a shallow surface-level biopsy, they can look practically identical under the microscope. True AFX is primarily dermis-centered, right? However, significant extension deep into the subcutaneous fat, along with other adverse microscopic features, well, that supports a classification of PDS. Now, a single finding doesn't automatically establish the diagnosis all by itself, which is exactly why having an adequate deep tissue sample is absolutely critical to separate these two lanes. We hit a really similar critical fork with DFSP, which is short for dermatofibrosarcoma protuberans. Conventional DFSP typically acts as a local control problem. It sends these little finger-like projections deep down into the tissue, but distance spread, that's pretty uncommon. But if the pathology report notes a fibrosarcomatous change, that means a part of the tumor has actually transformed into a higher-grade sarcoma pattern. That aggressive metastatic biology completely alters the whole shebang. Your surgical, imaging, and staging plans change entirely. When we're navigating extramammary Paget disease, or EMPD, there are 4 totally distinct forks we have to evaluate. First, is it primary to the skin itself or secondary to some nearby internal cancer? Second, is it intraepidermal, meaning it's just confined to the surface, or is it invasive? Third, are we dealing with a localized field, or is there regional spread to the lymph nodes? And finally, fourth, is there an associated malignancy present? This just brilliantly highlights why pathology matters so much. Deep dermal invasion of at least 1 millimeter moves EMPD entirely beyond just a simple surface field problem, right into a higher risk pathway. For sebaceous carcinoma, your routing depends really heavily on both location and hereditary factors. First up, we differentiate periocular sites, like on the eyelid, which might actually need specialized eye surface mapping, from extraocular sites. We also absolutely have to assess the risk to regional lymph nodes. And importantly, because sebaceous carcinoma can sometimes be a clue from your Tor or Lynch syndrome, we look closely at tumor mismatch repair testing. If that testing comes back abnormal, it should absolutely prompt consideration for genetic counseling. But keep in mind, an abnormal screen is not in itself a Lynch syndrome diagnosis. Okay, let me jump in for a quick reset here. If having the label rare doesn't automatically mean a death sentence or a massive medical emergency, how do we figure out our actual risk when there are just so many different diagnoses packed under this one big umbrella? It's a great point. To understand risk, we have to look at the numbers for each specific diagnosis entirely separately. You can't just group them. For DFSP, a U.S. SEER-18 registry study that covered the years 2000 through 2010 showed an incidence of 4.1 new diagnoses per 1 million person-years. Remember, that's a population rate, okay? It's not a calculation of one specific person's individual risk. And for that specific cohort in the registry, the 10-year relative survival was an incredibly high 99.1%. Now let's contrast that directly with Merkel cell carcinoma, or MCC. A separate SEER-18 study for the calendar year 2013 calculated an age and sex-adjusted incidence of 0.7 new diagnoses per 100,000 person-years. This rate rises sharply with age, so it's absolutely not a universal risk metric for every age group. These two examples aren't head-to-head comparisons, but they prove exactly why we simply cannot pull the prognosis of entirely different diseases together. Because these diseases behave so differently, their treatment timelines are naturally going to be different too. Just look at the MCC lane here. MCC has a meaningful chance of occult lymph node involvement, meaning it's there even when nothing feels enlarged to the touch. Because of that, a sentinel lymph node biopsy should be discussed early on. Generally speaking, this lymphatic mapping is performed before a definitive wide excision when feasible. Why? Because cutting into the tissue first can alter the drainage pathways the team actually needs to map. Within that same MCC lane, age plays a completely crucial boundary role. If MCC is diagnosed before age 50, that finding should prompt consideration of genetic counseling and testing. Now, we strictly frame this as a prompt for consideration. It is not some automatic mandate you have to follow, but it is definitely a critical discussion to have with your care team. It's also vital that we strictly separate these distinct pathways so we don't end up applying one single rule to everything. For instance, microcystic adnexal carcinoma, or MAC, is this subtle tumor that often tracks deep around nerves. Cutaneous angiosarcoma, on the other hand, is a broad blood vessel tumor that requires prompt staging by a multidisciplinary sarcoma team. These two require entirely different approaches. No viewer should ever assume that every patient with either diagnosis automatically requires the exact same multidisciplinary plan. As you sit down and read a pathology report, you really want to look for crucial risk words. Think of them as stop signs on our routing map. Words like fibrosarcomatosis, paraneural invasion, poor differentiation, or significant fat infiltration. These specific terms explain exactly why a care plan might suddenly shift from primarily a surgical excision into one that requires imaging, radiation, or maybe bringing in a medical oncology team. Wait, so if the surgeon goes in, removes the tumor, and says the skin margins are totally clear, doesn't that mean they're cured and the care is just complete?
You would think so, right? But for tumors with deep or systemic risks like MCC or angiosarcoma, a clear skin edge simply does not complete your care. We rely on what's called permanent pathology. That's a detailed review of processed tissue, particularly the central tumor itself, to measure the exact depth, and to look for those risk features we talked about that go way beyond just the skin margin.
So, what are the actionable, neutral next steps you should actually take with your clinician? First, make sure you obtain your complete pathology report. Second, ask if a deeper or complete tumor specimen is needed to establish the exact diagnosis. And third, ask if imaging, nodal staging, molecular testing, or getting an expert dermopathology review could change your care before you proceed with any specific treatment. Once those exact diagnoses and staging questions are crystal clear, you are ready to compare the treatments that actually fit your specific pathway. So look closely at your own pathology report. Which route are you really on? Are you ready for the rare skin cancer treatment options step? Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together.